Good morning, Baystate Ultrasound. For those of you I haven't met yet, I'm Dr. Dan Kowal, and I'm excited to talk to you this morning about ultrasound of GU infectious disease. This lecture will also be available for SDMS CME credit, but not until after April 19th, since their CMB system's currently down. And then a video of this presentation will also be posted on the Baystate Health YouTube channel, so you can check it out there. All right, so I'll give you an overview first. So I'll be talking about pyelonephritis initially, and we'll talk about complications like abscess, pyonephrosis, emphysematous infections, which is a gas-forming infection, and then also mimics. And then we'll review cystitis, including gas-forming cystitis. And we'll talk about epididymitis and orchitis, along with abscess, and how to differentiate a complicated hydrocele from a pyocele. Mimics there as well. And then I'll finish with pelvic inflammatory disease. We'll review early and late findings, how to differentiate a tubo-ovarian complex from an abscess, and then we'll talk about endometritis. So let's start with pyelonephritis. So here we have a sagittal view of the right kidney, and you can ignore that renal stone that's nicely isolated for measurement there. And notice how there's this wedge-shaped area of increased echogenicity in the upper pole. And then when we add color Doppler, you can see that that area is also hypoperfused. So this is a classic appearance for pyelonephritis. And urinary tract infections are the most common urologic disease. It's usually due to E. coli, and most are uncomplicated and only involve the urinary bladder. So we see pyelonephritis when that infection migrates to the upper urinary tract, or if it's seated there hematogenously. And at that point, both the renal pelvis and the parenchyma become inflamed. The hematogenous spread we don't see as commonly. That's usually seen in the setting of intravenous drug use or endocarditis, or if a patient has some other extraurinary site of infection. So here's an example. This is a female patient with a history of fever, chills, headache, and nausea and vomiting. So a classic history for pyelonephritis. But on this ultrasound, we don't really see much going on. The kidney looks pretty normal, that right kidney. However, when we look at the CT scan, you can see that the right kidney here has this ill-defined hypodensity there in the interpolar region. There it is there on the coronal image. You can see there's also some urothelial thickening here in the right renal pelvis. So there is right pyelonephritis. And then in retrospect, you can see that area. It spans out the interpolar region a bit, but it's isoechoic. So this is an example of pyelonephritis with an essentially normal ultrasound. And that's actually what we usually see. The ultrasound's only abnormal in about 20 to 24% of cases. When it is abnormal, though, what you'll see is renal enlargement, urothelial thickening, patchy wedge-shaped hyperechoic areas if there's hemorrhagic change, or hypoechoic areas if there's edema. And then that can give you an overall loss of the normal corticomedullary differentiation. When we add color Doppler, you can get hypoperfusion due to vasoconstriction, and that's because in the area of pyelonephritis, you have this interstitial edema with tubular obstruction, and it stretches the interlobar arteries, decreases the blood flow. Now, a newer technique that we have on our Samsung machines is this microvascular flow, and that gives us a bit better view of the detection of pyelonephritis. And studies have actually shown that that's superior to color Doppler for detecting pyelonephritis. So let me show you some examples of that. So here's a patient. You can see the right kidney here with color Doppler imaging. You might wonder, is this an area of pyelonephritis? We have this ill-defined echogenic wedge-shaped area in the upper pole, and it seems like it might be hypoperfused. But when we add microvascular flow, the MV flow, you can see that that area is normal. It totally fills in with the vascular flow, so there's no evidence of pyelonephritis there. So it gives you a much better look at that parenchymal vascularity. You can really see these interlobar arcuate and these peripheral interlobular arteries. So not only can you detect pyelonephritis better, but it also outlines renal infarct much better. And if there's a mass there, that will also be more conspicuous. So let me show you some examples of that. So this was an 8-year-old male who had CT showing severe right pyelonephritis. You can see these ill-defined hypodense areas there in the right kidney with some stranding there at the lower pole. And then if we look at the pelvis, there's also the circumferential bladder wall thickening there. So there was cystitis as well. And the patient ended up having a follow-up ultrasound 6 weeks later to see if the infection had resolved and if there were any other complications. And you might wonder, is there persistent pyelonephritis there in the upper pole? It seems like it's a little hypoperfused. And that's actually an area, too, where we often get a bit of echogenic artifact. But when we use the microvascular flow, you can see that area really fills in nicely here, and there's no evidence of residual pyelonephritis. The only thing you see that's not perfusing are the renal pyramids, which normally that's not very vascular. So great use of microvascular flow to exclude the diagnosis of pyelonephritis here. Here's a different patient. This was a 52-year-old female who had subtle pyelonephritis in the upper pole of the left kidney here. You can see this vague hypodense area on CT. And then an ultrasound was done, and you might wonder, is that the correlate there, this ill-defined echogenic focus? Because of our habitus and the depth of the kidney, we didn't get great perfusion with color of that area, so it's difficult to say what's going on. But when we add the microvascular flow, you can see that area is nicely outlined. It's clearly hypoperfused when we really focus down and interrogate just that upper pole. So there is ongoing pyelonephritis there. So the microvascular flow is a great way to evaluate the renal parenchyma for subtle lesions and pyelonephritis. Now here's an example of one of the complications of pyelonephritis. So we have this heterogeneous collection with ill-defined echogenic margins, and then a bit of peripheral flow on power Doppler. So this is typical for a renal abscess. And so while it is very helpful to identify whether or not there's pyelonephritis and the extent of it on ultrasound, really we want to look for the complications of pyelonephritis on ultrasound. So that includes renal and also perinephric abscesses, renal obstruction, and then gas forming or emphysematous infection. So with renal abscess, as in this case, you'll see a complex fluid collection or a cystic mass. And you'll have these low-level echoes where there's liquefaction here. And it may have an echogenic rim depending on the maturity. So early abscesses will not have a rim. Later on, they'll start to develop this abscess. This one was fairly mature. And the problem is it can be solid and sometimes difficult to differentiate from neoplasm. So that's similar to liver abscesses when we have the infection Klebsiella pneumonia. That can often look like a solid mass, but it's actually just an abscess. So here's an example. This was a patient who had pyelonephritis, the right kidney here. You see this expansile area in the intrapolar region. It looks a little isoechoic. It's nicely outlined on power Doppler imaging here. And then when we use color Doppler, we see that even more conspicuously as what looks like a cystic and solid mass. We have this area of liquefaction in the center there, that anechoic focus. And this is an example of a renal abscess appearing as a solid mass. Much easier to see there when we add calipers. And the patient had an MRI that just confirms that there is actually a non-enhancing abscess there. If this was a mass, it would show some more solid mass-like enhancement. So for treatment for renal abscess, the small abscesses can often resolve just with antibiotics, but larger abscesses will require percutaneous drainage or surgery. So now here's a tricky case. This is a patient, you can see the left kidney here in the upper pole. We have this, what looks like a fluid collection. It's heterogeneously hypoechoic. There's even some posterior acoustic enhancement. Here it is on transverse imaging. But then when we add color Doppler flow, what's going on there that doesn't really go along with abscess? We can see there's actually vascular flow within the, quote, collection. And then when we look at the CT scan, this is not a collection, but it's a solid hypoenhancing mass. And this is typical for renal lymphoma, which can really mimic an abscess, as you can see here. It typically actually looks fluid-like, but larger lesions like this will show internal flow. So this was a patient that had inflammatory bowel disease and had a history of recurrent abdominal and pelvic abscesses. So they had a high clinical suspicion that this was an abscess. But the patient was also on immunosuppressive medications, which have an unfortunate side effect of sometimes causing lymphoma. And this was the patient's contralateral kidney. You can see there's another small, what looks like a collection in the upper pole. This one is problematic because we don't see any color flow. But when we look at the CT scan, that area corresponds to another focus of lymphoma. So the additional problem with renal lymphoma is sometimes small lesions won't really show much flow. But the good news is it's the most common appearance for renal lymphoma is multiple masses. So this is the same patient, and you can see on the contralateral kidney, we do have renal lymphoma there as well. So if you see multiple lesions, the larger one should show flow. And this is the same for lymphoma elsewhere. I've seen hepatic lymphoma also mimic abscess. All right, so let's look at a different complication. This was an elderly female that had a history of urosepsis. So you can see here the renal pelvis is really expanded in the right kidney here, and it's filled with all this echogenic debris. There's some urothelial thickening about that with some increased flow on power Doppler. So when we look at the contralateral kidney, we see similar findings. There's all this layering debris within the left renal collecting system, and the collecting system's dilated. This lower image is showing you debris expanding the peripheral calyces. And when we look at the cine clip, you can see that even more effectively. So we see the dilated collecting system containing debris, and that's extending out. There's even a bit of urothelial thickening here in the beginning of the ureter. So this is a typical appearance for pyonephrosis, which is an obstructed and infected collecting system. So what happens is echogenic pus fills or layers throughout this dilated collecting system. And the treatment is percutaneous decompression. So this will not resolve with antibiotics. That's why it's very important to detect. These patients usually will need some type of decompression because otherwise they can develop advanced sepsis and renal failure. The problem is not all patients with pyonephrosis will have visible pus on ultrasound. So if you have a patient with a severe UTI and they have hydronephrosis, it's something we have to consider, even if we don't see layering debris like this. The other problem is hematonephrosis, or blood within a dilated collecting system, can have a similar ultrasound appearance. But the clinical history should be different. With hematonephrosis, you'll have hematuria. You won't have usually urosepsis. Also, it would be unusual to have bilateral hematonephrosis. Usually it would be unilateral due to a stone or a tumor, unless the patient had some type of coagulation disorder. All right, so this is a different complication we can see with pyelonephritis. And the clue here is it's an elderly male with diabetes. And you're seeing all these linear or curvilinear echoes kind of in the non-dependent aspect of the kidney with all this dirty shadowing and ring down artifact. So instead of a dense poster-acoustic shadow here, we have this grainy shadow that tells you we're dealing with gas. So this is a emphysematous pyelonephritis. So this is a serious necrotizing gas-forming infection. And it's usually due to E. coli and in patients with poorly controlled diabetes. And you'll see these bright reflectors with dirty shadows or ring down artifact. When this involves the parenchyma, the treatment is usually nephrectomy because this infection will just spread. But you have to be careful. And here's the CT scan for this patient. And you'll notice that this gas here, these little black areas, are actually confined to just the renal collecting system. They don't extend all the way out to the cortex where the parenchyma is. And this is a coronal reformatted image that mimics an X-ray, and you can see that even better, that the gas is all central there in the collecting system. So because this is isolated to the collecting system, this is actually emphysematous pyelitis. So this is a less serious infection. And again, the gas is in the collecting system, not in the parenchyma, which would indicate pyelonephritis. The problem is on ultrasound, it's difficult to differentiate parenchymal gas from collecting system gas, and in those cases, CT can be helpful. Often if the parenchyma is involved, the whole kidney or most of it will be gassed out, and you'll see that extending to the cortex. So here's a case that kind of puts a few of these things together. We have the right kidney here, and you can see that there's this perinephric collection here in Morrison's pouch. And there's also a bit of urothelial thickening here, this thick echogenic area here along this peripheral calyx. And then when we look at this sagittal and transverse image, you can see that that does have, even though it looks a little mass-like and solid here, we do have this central liquefactive area. So we've got a perinephric abscess. And then if we look further, you can see these curvilinear and linear echogenic areas with dirty shadowing. So we have some gas there. And then one thing that you can do to increase the conspicuity of gas is add color Doppler, and you get twinkle artifact, which that's definitely not specific for gas. As you know, you can see that with renal stones, but it usually has a bit more dramatic twinkling compared to just renal stones. So it can kind of outline the pathology a bit further. And this is where cine clips are often quite helpful. So you can see here that we see all this areas of gas here within the collecting system. And again, that urothelial thickening right here, and the perinephric abscess. And then look at how echogenic that perinephric fat is. That tells you that there's quite a bit of inflammation going on. Just like when we see echogenic fat around an inflamed appendix. And you can see around that we've got this perinephric edema as well. So this is a pretty severe gas-forming infection with a perinephric abscess. So the patient went on to CT, and here you can see that the collecting system is filled with gas quite extensively. We don't really see any in the parenchyma though. So this is Emphysematous Pyelitis with that perinephric abscess that we saw. And we didn't stop there. The patient then had a CT with rectal contrast. You can see here's the catheter. And that contrast ended up in the right collecting system, which is never a normal communication. There's also some gas there. We can see those black areas in the non-dependent collecting system. So this turned out to be emphysematous pyelitis due to a colureteric fistula, an abnormal communication between the colon and the ureter. So that would need to be repaired surgically. Now here's a potential pitfall. There's that earlier case of emphysematous pyelitis that I showed you. And then this looks like another case of emphysematous pyelitis, doesn't it? But then when we look at the x-ray for this case, what do you see? Well, there's a Staghorn Calculus here. And you can see the definition of a Staghorn Calculus is a stone that extends from the renal pelvis here, and then would extend into at least 2 calyces. But we have multiple calyces involved here. This is a huge stone pretty much filling up the whole collecting system. So that's a potential pitfall, especially when it's large, because it can mimic an emphysematous renal infection. The clue is that you get more posterior acoustic shadowing for a stone than you do with emphysematous pyelitis. That's more of a dirty shadow. And another clue is you can see the anterior margin of the stone is more sharply defined. You can see these reflectors here from the gas are kind of ill-defined and linear. This looks like more like a stone interface that you would see closest to the beam. All right, so let's continue down into the bladder. We'll talk about cystitis here. So with cystitis, one of the hallmarks is bladder wall thickening, and you can see this case here has pretty extensive circumferential wall thickening. And generally, the wall is normal at 3 millimeters in a normally distended bladder. And if it's underdistended, it can get up to at least 5 millimeters. And that's definitely not specific for cystitis. We can see that with bladder outlet obstruction, neurogenic bladder, radiation, or neoplasm. Something else we sometimes see is wall hyperemia, although that's less common. And a key is this floating or layering debris, which we have quite a bit of here. This is actually the same patient that had the pyonephrosis that I showed you earlier. A tremendous amount of debris there. And particularly in children, studies have shown that this is associated with a 4-fold increase in having a positive urine culture. And interestingly, it's regardless of the debris extent. So even if you just have a few scattered low-level echoes, that's definitely worth mentioning in pediatric patients because that really increases the risk that they have would have a positive urine culture, and that could be pursued. And just to show you the potential pitfall here of underdistension, this was a 20-year-old patient who had a post-void residual here of 25 cc's, which is normal, but then is this abnormal wall thickening? The wall measured up to 6 millimeters. But when we look at the pre-void volume, which is quite vast, over 600 cc's, the wall is almost non-detectable. So this is a normal bladder that just really decompressed and had some thickening. So you do have to be careful with that underdistension. So this was a patient, an elderly female who had urosepsis, and we see quite a bit of layering debris there in the bladder. And there's no internal vascularity within this debris. And it's also important to move the patient around whenever we're evaluating the bladder, if there's anything within it. That's one of the advantages about ultrasound, it's so dynamic. And you can see this debris was free-flowing and just kind of pooled on the side when the patient was in decubitus position. So there's nothing underlying that area. So this is a typical appearance for cystitis. And usually it's infectious, and again, it's often due to E. coli. And just like pyelonephritis, it's more common in females due to the shorter urethra and propensity for retrograde flow. But you do see it in men who have bladder outlet obstruction or prostatitis that can seed the bladder. So this was actually a male patient, and you can see on this sagittal sweep, we've got this layering debris there, kind of pooling in the dependent aspect of the bladder. Also, it's a nice view of the prostate gland here. You can even see the prostatic urethra coming down and the seminal vesicle here. But then when we look at the transverse image, it all layers out. When we put the patient in decubitus, though, look at how it looks a bit more mass-like. However, when we turn them the other way, it then kind of spills out, but still almost adheres to itself. So this is kind of a typical appearance for a clot mixed with some debris. So this patient actually had hemorrhagic cystitis, They had had a liver transplant and were on tacrolimus, which is an immunosuppressant, and the cystitis was thought to be secondary to that medication. So it's important to keep in mind you can have non-infectious cystitis, like in this case. So don't let the finding of a negative urinalysis dissuade you. So medications can cause that if the patient's had radiation for pelvic malignancy. Also, there's certain autoimmune diseases that can cause cystitis, and there's an idiopathic type called interstitial cystitis. So here's a different type of cystitis. This was an elderly male. The clue here again is diabetes. Also had a history of chronic UTIs and a neurogenic bladder. So at the bladder dome here, we've got all this echogenic gas that's shadowing out the lumen. And on this sagittal view, you can see it's kind of non-dependent here, right? It looks a little bit linear. And we could see that a bit better on this cine clip, how it's very linear and almost seems to be isolated to the wall, right? Here's the wall here, and the gas kind of appears to be located within that wall. When we look at the correlative CT scan, you can see indeed there is quite a bit of intraluminal gas here, but there is also gas in the wall, which you can see here on these images. And then there's quite a bit of perivesicular inflammatory stranding. That's what we're seeing on this coronal image, telling you that there's cystitis. So this is emphysematous cystitis. So this is when you have gas not only in the bladder lumen, which we can see commonly just from Foley catheters and instrumentation, but it's also in the wall, which is never normal. And so that would be the intramural gas. And you'll again see these dirty shadows and ring down artifacts. And it's often caused, not surprisingly, by E. coli, which can be a gas-producing bacteria. And just like emphysematous pyelonephritis, we see it more commonly in patients who have diabetes. So you want to be aware of that if you're scanning a patient that has poorly controlled diabetes. What's different, though, is this is not a surgical emergency, unlike emphysematous pyelonephritis. The bladder will not be removed in this case. It's often just treated with antibiotics and control of the patient's blood sugar. So if you're scanning and you see gas in the bladder, try to move the patient around to see if you can isolate, is that gas just in the lumen or is it in the wall? Because they may want to more aggressively treat with antibiotics for that. All right, let's go on to talk about epididymitis and orchitis. So this was a patient who had a history of scrotal pain, and you could see that the epididymis is a bit enlarged, heterogeneously hypoechoic. When we add color Doppler, we have marked hyperemia diffusely throughout the epididymis. And this is a classic appearance for acute epididymitis. There's also a small hydrocele there. So this is usually bacterial, and it depends on the patient age, actually. In children, it's often due to E. coli. In adults less than 35, it's more commonly a sexually transmitted disease. So we'll see gonorrhea and chlamydia. But then over 35, E. coli again becomes more common, as well as Pseudomonas. And it's typically due to retrograde spread of the organism from the urethra or the prostate gland. And the infection usually starts in the tail and then moves to the body and the head. So once you see it at this point, it's more advanced. And the typical findings, the epididymis will be enlarged, hyperemic, and hypoechoic. But often you'll just see hyperemia first before you see any of that grayscale change. So it's important to add color Doppler. So here's an example. This is a patient with scrotal pain, and you can see the left epididymal head here looks pretty normal, right? There's a bit of flow there, but not diffusely throughout it. It doesn't look enlarged or heterogeneous. However, when we look at the tail, look at that. That's really abnormal. It's expanded. It's heterogeneously hypoechoic. And then when we add color Doppler, it's markedly hyperemic. So this is an example of focal epididymitis. And again, it's most common in the tail. So you definitely don't want to stop when you see a normal epididymal head. You want to really investigate the whole epididymis because the infection usually starts in the tail. And here's a fake out case. Is this acute epididymitis? Well, it looks a little suspicious, right? We see an enlarged, heterogeneously hypoechoic epididymis. But then when we add color Doppler, it's not really hypervascular at all. And this is a potential mimic of epididymitis that we can see after vasectomy. And what can happen is the epididymis can become engorged due to dilation of the tubules. So it's similar to the tubular ectasia of the reedy testes that we see at the testicular mediastinum, but this is extended to involve the epididymis. And the clue is you'll see these little tiny anechoic spaces separated by echogenic walls. Whereas with epididymitis, it should look more solid and just heterogeneously hypoechoic. And the key here is you shouldn't see any hyperemia. So this is a normal post-vasectomy finding, but it could be associated with that post-vasectomy pain syndrome. So some of the complications to be aware of with epididymitis would be this case. So there's a heterogeneously hypoechoic focus there in the epididymal tail, and then when we add color Doppler, there's peripheral hyperemia surrounding it here. So this is a pretty classic appearance for an epididymal abscess. So epididymal abscess, it's usually a complex avascular fluid collection, but it's often typically treated with just antibiotics. These usually don't need to be drained, and they're also very small. A more serious complication to look for, though, is testicular ischemia and infarct. So when epididymitis is advanced, it can actually obstruct venous outflow from the testis. So then you'll get an appearance similar to what you'd see with torsion. You'll see decreased color Doppler blood flow, and then in the early stage, you might just see reverse testicular diastolic arterial flow, just like you'll see with intermittent or early torsion. So definitely, if you see a really severe epididymitis, carefully evaluate that testicular blood flow. So here's a patient. This was an 8-year-old male who came to the ED for this continued testicular pain. And notice how the epididymis is heterogeneously hypoechoic and enlarged. When we add color Doppler, it's very hyperemic. There's also a small hydrocele. And then interestingly, there's this area here, this ovoid heterogeneously hyperechoic focus that seems to be avascular. And then when we add microvascular flow imaging, you could see that it's avascular there. We don't see any flow, but we do see hyperemia throughout the epididymis. And then this cine clip nicely shows that there's that hyperemic epididymis. And this area, we can confidently say, is truly avascular with the MV flow. And the testicle here also has normal flow. There's the small hydrocele, and that area is avascular. So the patient actually came back to the ER 3 days later, and the appearance was similar. You can see that the epididymis is hyperemic, but this area is non-vascular. So what's going on here? So this is an example of a non-infectious cause of acute epididymitis. And this was epididymal inflammation that was secondary to a torsed epididymal appendage. So that's what we're seeing there, that enlarged heterogeneously echogenic area. And this patient actually had a negative urine dip that was repeated. And this is important to identify because then you can avoid treating a pediatric patient unnecessarily with antibiotics. This was just conservative therapy and was expected to resolve. So some other non-infectious causes of acute epididymitis to be aware of is trauma, also vasculitis, and certain medications like amiodarone, as well as autoimmune diseases. And here's an example. This is a patient that had scrotal trauma, and you can see how that epididymis is enlarged and hyperemic due to a post-traumatic contusion. So an example of non-infectious acute epididymitis. All right, so the appearance of epididymitis should be quite familiar now. You can see here's another example. This one's very hyperemic, and then the scrotal wall is also showing quite a bit of vascularity. When we look at the right testis there, you can see that there's skin thickening overlying that right hemiscrotum relative to the left. And then notice how the testis is heterogeneously hypoechoic. So when we add color Doppler, as you can expect, it's extremely vascular, showing that there's quite a bit of inflammation. So this is not just epididymitis, it's acute epididymo-Orchitis. So just like epididymitis, this tends to be bacterial. And with 20% of epididymitis cases, you can see this associated orchitis. And scrotal infection will usually start in the epididymis, but then it can spread to the testis, as in this case, and even to the scrotal sac or the scrotal wall. And the key here is orchitis is usually secondary to epididymitis. We don't usually see isolated orchitis, particularly in adults. In children, we can occasionally see it due to viral etiologies like mumps. And just like with epididymitis, the typical findings will be enlargement of the testis, and it will also become hyperemic and hypoechoic. And some of the complications, just like with epididymitis, we can get an abscess, which will look similar. You can have a complicated hydrocele and then a pyocele, which I'll explain in a moment. And then again, scrotal wall inflammation or even abscess. So it's common to get some scrotal wall cellulitis. So let's look at a case. This is a right epididymitis. You can see that involving the head here. And then when we look at the rest of the scrotum, there's a hydrocele, but it's more than just that. You see how these a network here of reticular echogenic strands here, showing you that it's a complicated hydrocele. But there was no significant peripheral vascularity. And also notice how it doesn't really have any mass effect against the testis. And we don't see much floating debris within it. It just seems like a mesh of irregular strands here. So this is typical for a complicated hydrocele. So this does not need to be drained. This will tend to resolve with treatment, antibiotic treatment of the epididymitis. Now compare that to this case. So here we have a larger collection here in the hemiscrotum, and it has these low-level echoes throughout it, as well as a regular mesh-like network here. And it's also showing quite a bit of mass effect deforming the testis. And when we add color Doppler, the testis and the epididymis here are markedly hyperemic, so we have Epididymo-Orchitis with this mass effect from this large collection. Now, if you look at the cine clip here, it shows it nicely, how heterogeneous and this collection is. It almost looks like it has what sometimes is called a falling snow sign from all the debris layering within it. And notice that mass effect against the testis. And then you can see the epididymis here is markedly heterogeneous. These little echogenic areas, we were wondering, could this be gas? Is there a gas-forming infection here? So for that reason, the patient went on to CT. And you can see in that left hemiscrotum, we don't see any gas, but we do see rim enhancement about that collection. And this is very typical for a Pyocele. So a Pyocele is a purulent fluid collection that has septations in these internal echoes. And it will often have mass effect because it's not just fluid, it's pus and fluid. And it might have gas or peripheral hyperemia. It's important to identify this because while these may resolve with antibiotics, there's a higher likelihood that they'll need surgical debridement compared to a complicated hydrocele. In this case, actually, I was expecting to go to surgery, but the urologist was able to treat it conservatively with antibiotics. So just be aware of that mass effect and internal debris. All right, so here's an example of the scrotal wall infection that we were referring to. Oops, sorry. You can see that there's quite a bit of edema here within the anterior scrotal wall. And on this curved view, it shows you just how extensive it is, particularly surrounding that left hemiscrotum. Now, fortunately, the technologist didn't stop there. The patient was complaining of a palpable area superiorly at the margin of the scrotal sac. And in that area, there was this heterogeneous, ill-defined angular collection here with peripheral hyperemia, very close to the skin surface. And this is a typical appearance for a scrotal wall abscess. And this underwent incision and drainage by urology, which yielded some bloody pus. So these can develop from a testicular abscess if it ruptures, or they can just arrive in the soft tissues of the scrotum just due to cellulitis and other inflammatory processes. And that's what happened in this case. And what's interesting is they can occur at the scrotal perineal junction, which is a little higher up. So the teaching point there is if you're only imaging the scrotum by an anterior approach, you could miss this. So just be aware of what the patient might be complaining of, or to scan that kind of scrotal perineal junction. And you might pick up an abscess, as in this case. Now here's a tricky case. So this was a 55-year-old male that had enlargement of the left hemiscrotum. And it looks like we might have orchitis here, right? The testis is heterogeneously hypoechoic and enlarged, and it's also hyperemic. And when we compare that to the right testis, we see that again, that it's clearly enlarged and hyperemic relative to the right. So is this isolated orchitis? Because the epididymis look normal. Well, this is an adult patient, so you want to be careful calling orchitis. And this actually turned out to be testicular lymphoma. So testicular lymphoma, it's trying to fool us again, this time in the testicle, and it can really mimic orchitis. So just be aware if you don't see associated epididymitis. Also, leukemia can sometimes have this appearance as well, and even diffuse seminoma, if it's just completely replacing the testis, you might initially think it's orchitis. Something that's helpful is patients with orchitis will be more likely to have pain and tenderness, and again, associated involvement of the epididymis. And it should decrease or resolve on a follow-up, whereas this will not. Now, here's a different type of scrotal infection. So you can see the epididymis is enlarged and heterogeneous, but extremely heterogeneous, right? And there's also this complicated hydrocele next to it with full of low-level echoes. Almost looks like an endometrioma, right? And then if we look at the inferior epididymis, it's just diffusely heterogeneously hypoechoic with these little irregular echogenic foci scattered throughout. And the color Doppler flow is increased, but it's more at the periphery this time. We don't see it diffusely throughout. And this is actually chronic tuberculous epididymitis. So this is rare, but actually chronic infectious epididymitis is usually granulomatous, and TB is the most common granulomatous disease of the epididymis. And you'll see findings will look a little different than bacterial epididymitis. Instead, you'll see these hypoechoic nodules due to granulomatous masses, scattered calcifications, and then more of a necrotic appearance. That's why we don't see any internal flow. It's kind of peripheral. And you'll see these complicated hydroceles, and you might also see fistulas and sinus tracts extending out. Now, this actually looks a little similar, doesn't it? And that's a clue. This was a 32-year-old male who presented with a clinical suspicion of a testicular neoplasm. And you can see in the testis here, there is this kind of expansile mass-like focus that has some peripheral flow. And the rest of the testis looks okay, but it does look rather suspicious. The patient also had a CT scan showing, again, that kind of left testicular mass, and actually underwent orchiectomy. And it turned out this was actually tuberculous orchitis. So just like tuberculous epididymitis, this is chronic, and it's usually due to direct spread from an epididymal tuberculous infection, which you tend to see more in late-stage disease. You can rarely have hematogenous spread just to the testicle without epididymal involvement, but that's not very common, and that's actually what this patient had. That's why clinically there was a higher suspicion that this was a tumor, because there was no epididymal involvement. Often, even though we don't see it commonly, TB orchitis will be just an enlarged testis with multiple small hypoechoic nodules. This is an example where it's solitary. But just notice that appearance, how it looks very similar to the epididymal granulomatous infection, kind of necrotic with peripheral vascularity. All right, so the last thing I'll talk about is pelvic inflammatory disease. So this is a common cause of acute pelvic pain. We see it frequently in the emergency department, and patients often have the triad of fever, leukocytosis, and cervical motion tenderness. And most commonly, it's associated with STDs and maybe polymicrobial. So we see it with chlamydia and gonorrhea, rarely with tuberculosis. And actinomycosis is interesting because there's a higher incidence of that infection in patients who have chronically indwelling IUDs. So that's something to consider in a patient who has an intrauterine contraceptive device in place. And the infection typically spreads by an ascending infection from the vagina or cervix, but it's very important to be aware that this can occur due to diverticulitis or ruptured appendicitis. So you will see this in patients who are either not sexually active or postmenopausal, because it can be caused from a GI source. And often in that case, you'll, instead of the typical bacteria, you might see Enterobacter or other coliform agents. And we see it most commonly in premenopausal women. So what will happen is you'll get inflammation of the endometrium causing endometritis. The tubes will become inflamed, causing salpingitis. That can evolve to pyosalpinx from tubal occlusion, and then ultimately tubovarian abscess from these periovarian adhesions. So I'll kind of show you examples of each of these. So starting with the early findings, the ultrasound's often normal, and it can be very subtle. You might see with endometritis just a little endometrial thickening or fluid, but that can be nonspecific. With salpingitis, as the tubes become inflamed, they'll get a bit thickened, as in this case, but you can see this is rather subtle. Oophouritis we'll see with the ovary becomes a bit inflamed. You might see the ovary enlarging a bit and have a polycystic appearance, as we're starting to get in this case, but that's also a difficult call because these are often young patients that normally have large ovaries with a polycystic appearance. And you might start to see an ill-defined margins of the ovary and the tubes because of this surrounding inflammation, which we kind of get a sense of here. And then the free fluid might be a little complex because we're starting to get a bit of purulent debris, as you can see here. But again, that's not very specific either, right? Because we can see that just with the rupture of a physiologic hemorrhagic cyst. So you have to have kind of a high index of suspicion. Now, as that tubal inflammation progresses, though, then the findings become more apparent. So we'll start to see peripheral hyperemia throughout the tubal margins, as in this case. And a really helpful finding is the cogwheel sign, which you can see here as this little echogenic nubbin that we see at the tubal margin. So this is typical for tubal inflammation, and what we're seeing actually is thickening of the longitudinal folds, giving you that little, almost looks like a mural nodule, but it's small and they tend to be uniform. And this will really help you in differentiating tube from small bowel or ovarian neoplasm, because with bowel, you won't see this so sparingly. You'll see more like bowel folds, the little valvulente folds. And with ovarian neoplasm, you'll see if you have a mural nodule, it's usually more robust. Now, here's an example. Is this a cogwheel sign? It looks like we're seeing, are these little longitudinal folds we're seeing within this fallopian tube. There's even some peripheral hyperemia. Is this salpingitis? But then, no, look, it's just within the left ovary. So this is just a corpus luteal cyst, having that normal crenulated margin we sometimes see, that undulating fold as it starts to involute. So just be careful that you don't get faked out by this. This will clearly be intraovarian and focal instead of longitudinal and tubal shape. So here's a real case of a cogwheel sign. This is a patient who has a dilated fallopian tube here filled with debris, and you can see these cogwheel thickened longitudinal folds that we're seeing peripherally. When we add power Doppler, there's also some peripheral vascularity there. And this image is quite helpful to show you that it has a C shape. It's a tube folded on itself. So as the salpingitis progresses, that's when you start getting extension to a pyosalpinx. And this is when you get complex purulent fluid filling the tube with diffuse wall thickening, as we see in this case. And a really helpful clue is it will have a C or an S shape, which cystic ovarian neoplasm will not have that shape typically. And also, as the infection progresses, that purulent debris level, you'll actually see shift dependently as you move the patient around. And here we also have some peripheral hyperemia. This was a large pyosalpinx. And as these tubes continue to fill with pus, they become so heavy that they start dropping into the posterior dependent portion of the uterus. So here, notice these bilateral tubes are posterior to the uterus. And you can see that also on the CT scan on this transverse view. Here's the uterus here. And we have a dilated pyosalpinx on the right and on the left, both dropping down into the dependent portion of the pelvis. So that's something also that we don't tend to see very often with cystic ovarian neoplasms. They tend to not drop down. You can see this, though, with endometriomas, particularly with deep infiltrative endometriosis, as these kind of adhere to each other, and you get that kissing ovary sign. But again, that history will typically be different. And then the final stage of PID is when you get this tubovarian complex or tubovarian abscess. So let me just explain that. So tubovarian complex is when you have severe salpingo-oophorytis. The ovary and the tube will start to adhere to each other, but you can still distinctly identify the ovary from the tube. You can't really separate them, though, when you press against it with the probe. And then a tubovarian abscess is once that then evolves to these pockets of purulent fluid just replacing the ovary, and you pretty much lose the normal adnexal architecture. You end up just seeing this big multiloculated mass with septations and irregular margins, and you don't see normal ovary. So let me just show you an example of that. This patient actually had both a right tubovarian abscess and a left tubovarian complex. So here on the right, we have a classic tubovarian abscess. It's this big multilocular mass with all these pockets of purulent fluid. We don't really see normal ovarian architecture. When we look here, we can see there's a tube there that's dilated and filled with debris posterior to the uterus on the left. There we see it again. And then on this transverse view, you can see both. So there's that right tubovarian abscess, and then there's that left pyosalpinx, and then it's extending over to this ovary here, and you can still make out the ovary and the tube. So this is a tubovarian complex, but you can't separate this with the transducer if you're able to press against it because it's adherent. And there's the uterus anteriorly. Again, notice how these structures kind of drop down posterior to it. If only every image came labeled like this. No pressure. And then here's a CT scan just showing those same findings. There's that right tubovarian abscess where you don't have any normal architecture. But on the left here, you can actually see the pyosalpinx leading into that ovary with the cyst. So here's an example where things are kind of further along. We started as a tubo-ovarian complex, and then now this is more of a tubo-ovarian abscess, but it can be difficult to figure out what's going on just from static images. So here, notice that the tube is very thickened circumferentially, and there's debris within it. And then it extends over to this giant ovary here. It's difficult to make out normal ovarian structures enter that dilated tube. But you can see there's a tremendous amount of peripheral hyperemia throughout the tube and about that ovary. Quite a bit of inflammation here. And this is an example where the cine clips can be invaluable because it's very hard to tell what's going on just from the static images. And notice how well you can see that dilated, thickened tube posterior to the ovary. And then we don't really see any normal ovarian architecture. So it's a nice example of a TOA seen with the cine clips. So if you're having trouble capturing this well on the static images, don't hesitate to get a cine clip. And then this is the more advanced stage. Once you have a well-defined tubo-ovarian abscess, this patient actually had areas of gas within the abscess. You can see, like we've already seen before, these curvilinear reflectors with dirty shadowing and ring-down artifact. And there's quite a bit of hyperemia here in this giant TOA. Now, if you look closely, you might see there's actually a little bit of normal ovarian architecture intact. So you might say, Dr. Kowal, you said you can't see normal ovary with a TOA. Well, this is so large and abnormal that you can still confidently call this a TOA. You might still get bits of normal ovarian tissue, but this is all large collection. And here's the CT correlate just showing you that giant TOA on the left. And there's a little focus of gas there that we're seeing on ultrasound. Here's another example of a gas-containing TOA. And sometimes on transabdominal imaging, the gas will obscure the adnexa, and you might have trouble seeing it. So we're seeing that kind of dirty shadowing obscuring most of the adnexa, but on transvaginal imaging, you get a much better look at this area, and it's this heterogeneous collection with some linear reflectors there showing you that there's gas. And again, on the cine clip, you can see that a little bit better. There's that ring down artifact from that linear non-dependent gas. And if we look at the CT here, you can see why we were having such a hard time seeing that on ultrasound. With the transabdominal probe here, we're trying to scan through this gas, which isn't working. But transvaginally, we get a better look at the ovary, and there's quite a bit of gas in that adnexa. So why is it important to differentiate a tubo-ovarian complex from an abscess? Well, the treatment's a little different. A complex can often just resolve with antibiotics, but an abscess often needs percutaneous drainage. So here's an example. There's a large TOA here. We don't see any normal ovarian architecture. It's very hyperemic. On CT, it's this area here with a lot of stranding in the pelvis. This patient underwent percutaneous drainage, and on the follow-up, it's decreased quite a bit. And then if that doesn't work, the patient actually may need surgery, salpingectomy, and a pelvic washout. All right, so the last case I'll show you is this one. So this was a patient that had a fever, and notice how we're looking at a sagittal view of the uterus here. And you've got all these echogenic areas with posterior acoustic shadowing, but it looks a little dirty with some ring down artifact. And a clue here is the patient had a C-section a week ago. If we look at the patient's CT scan, you can see all this stranding here in the anterior abdominal pelvic wall here where the C-section was performed. There's a little C-section scar. And then there's just gas and fluid distending this endometrial cavity on this sagittal view. Here it is on the transverse image in an otherwise normal appearing postpartum uterus. So with that history, this is typical for endometritis. So endometritis we'll see actually most commonly after childbirth, or if there's been instrumentation like a biopsy or endometrial ablation. But we can also see it in pelvic inflammatory disease. And it's the most common cause typically for postpartum fever. And you'll see this kind of thickened endometrial cavity distended with fluid. But you have to be careful because it's normal to have gas in the collecting system, even several weeks after a vaginal delivery, let alone a C-section. But you should never see gas increasing, and a history of fever is concerning as well. But just gas by itself is not something to panic about. So here's that same case again with the endometrial gas. Here's a companion case with an echogenic endometrium. Is this also gas? Well, look here on this case, and we see dense posterior acoustic shadowing instead of this dirty shadowing here. So that's telling you more that this is calcification. And just like with that Staghorn calculus, look at the anterior margin of these echogenic areas. They're very sharply defined, more like a solid structure, like calcification, whereas the gas here is very irregular and ill-defined, often linear and curvilinear. And this is just endometrial calcification. This was a 75-year-old female. And in postmenopausal patients, this is actually not that concerning. It can be a normal finding, or at least a finding that's not considered worrisome for malignancy. All right, so just to quickly review, with pyelonephritis, only about 20% of cases will be positive on ultrasound, but you could use that microvascular flow to bring it out more. And the main complications we're looking for are abscess, pyonephrosis, which is an obstructed, dilated collecting system, and then a gas-forming infection. And if possible, try to differentiate between gas in the parenchyma, which is emphysematous pyelonephritis, more concerning and often goes to surgery, from gas that's just in the collecting system, which tends to be a less serious infection, which is just pyelitis. And then be aware of that scary lymphoma mimic, but it should have flow within it to differentiate from an abscess. And then emphysematous cystitis, try to identify if you can if the gas is in the wall as opposed to the lumen. With epididymitis and orchitis, look closely at the tail of the epididymis because that's often where the infection starts. And with orchitis, you might have a Pyocele showing mass effect against the testis compared to a complicated hydrocele. And then with PID, just be aware of the potential early findings might be subtle. With just some slight tubal thickening, you might start to see the cogwheel sign. So thanks for your attention. I'm happy to answer any questions now if you have any. You can unmute yourselves, or you can send me a chat. Or if you have no questions, that's fine too. Thanks for your attention and have a great day. I'll stop there.